As you know from the introductory lessons of interpreting fluorescein angiograms, hypofluorescence can be caused either by something blocking your view of the dye, or the dye is just not there secondary to retinal or choroidal non-filling. In this lesson, we will cover the main reasons for hypofluorescence of the retina and choroid secondary to blockage. If you look at previously published monographs or atlases on fluorescein angiography, the organization is most often based on the anterior or posterior location of the pathology, starting with vitreous opacities, then the interretina, midretina, subretina, or choroidal pathology. The next slide is an abbreviated representation of that organizational process. Here's a chart based on published flowcharts. You can see that hemorrhage, pigment, and inflammation can occur in almost any layer. However, when we examine a patient or look at a photograph, we start by describing the physical findings such as a hemorrhage, fluid, pigment, or white spots. After we describe what we're seeing, we then go to the location, whether it's preretinal, interretina, outer retina, or subretinal. We would say, I see a hemorrhage covering the major arcades, so it's probably preretinal. Or there's a creamy colored lesion. The retinal vessels pass over it, so it's probably deep in the retina. In general, we do not start with, in the outer retina, I see A, B, or C. So this portion of the atlas on hypofluorescence is organized by the physical findings and then the location. So it's organized more of our thought process. So let's look at the different clinical findings which can cause hypofluorescence secondary to blockage. And we'll begin with pigment because there's normal hypofluorescence centrally in the fovea and is secondary to different kinds of pigment. Here is a normal angiographic pattern of a normal fovea. There's normal hypofluorescence in the fovea caused mainly by the presence of melanin, xanthophyll, and lipofuscin. There are several reasons for this. The macular RPE cells are taller than surrounding RPE cells and contain more melanin and lipofuscin. Also, the outer plexiform layer has xanthophyll, and this also will block fluorescence. And finally, there's a natural capillary-free zone, so the retina itself does not have the fluorescein in that area of the retina. And all of these reasons lead up to the dark central area on a fluorescein angiogram, and this is absolutely normal. Any pigment will block the fluorescein dye. And at this point, I'd like to talk about melanin. Preretinal pigment is not commonly found, but the two most common causes will be a simple hamartoma or a combined hamartoma, or maybe a melanocytoma on the nerve. Rarely, a very intense epiretinal membrane may also have some pigment as well. Here is a very striking case of a simple hamartoma of the retinal pigment epithelium. It is courtesy of the West Coast Retina Case of the Month, published a number of years ago. Many times, these hamartomas are an incidental finding, as in this case, or there may be a slight decrease in vision. You can see that it is very black and just inferior to the fovea, and on the angiogram blocks the dye totally underneath it. The rest of the angiogram is normal. The very nice OCT shows that this lesion is at the inner surface of the retina. Now we will look at pigmentary changes deeper in the retina at the level of the pigment epithelium, and these examples would include choroidal folds, congenital hypertrophy of the pigment epithelium, and pigment from scars in the choroid. This patient has macular degeneration with geographic atrophy and also some pigment migration, as pointed out by the arrows. The hypofluorescence caused by blockage of the dye by the pigment stands out very well against the rest of her degeneration. She also has hyperfluorescence from transmission defects, which will be covered in another chapter of the atlas. This patient has bilateral pigment epithelial detachments. These detachments will sometimes have pigment migration on their surface, and sometimes it'll have what is called a hot cross bun look to the pigment. As with any pigment, it will block any dye posterior to it. The hyperfluorescence here is the collection of the dye in the pigment detachment itself. This is the final example of macular degeneration, and the pigmentary changes are more subtle than on the prior examples. You can see that there's a subtle amount on the color photographs, but you can see the scattered blockage on the fluorescein angiogram. The final example of pigment migration in the retina is presented here, and is quite dramatic. This patient has macular telangiectasia. Pigment migration to the superficial retina, especially temporal to the fovea, is one of the classic signs of this disease, and it is most often bilateral. Macular telangiectasia should be the first diagnosis you consider if you see this superficial black pigment temporal to the fovea. And you can see blockage on the fluorescein angiogram and some subtle hyperfluorescence at the lower edge and the temporal edge secondary to the telangiectatic vessels. Now we will look at pigmentary changes deeper in the retina at the level of the pigment epithelium, and these examples would include choroidal folds, congenital hypertrophy of the pigment epithelium, and pigment from scars in the choroid. Idiopathic choroidal folds most often occur in hyperopic patients. They may also be secondary to ocular hypotony or tumors behind the globe putting pressure on the posterior pole and flattening it out. This patient has idiopathic choroidal folds. She also has pattern dystrophy, which gives that yellow look to the fovea. This is a subject which will be covered elsewhere in the atlas. Choroidal folds are generally horizontal lines of light and dark pigment that you can see clinically. These can be seen even more easily on this patient on the red-free photograph. This is a fluorescein angiogram of the last patient. The dark hypofluorescent lines are the troughs of the choroidal folds. This is where the pigment epithelial cells are bunched together and where the pigment consolidates. This consolidated pigment and denser pigment blocks the dye, and that is why it is dark. The ridges of the folds have stretched pigment epithelial cells, and they become atrophic, and they have lost some melanin. With less pigment, there is hyperfluorescence. The late phase shows a similar pattern to the early phase, with some hyperfluorescence of the vitelliform lesion in this patient's pattern dystrophy. Congenital hypertrophy of the pigment epithelium, which oftentimes we call chirpy, are lesions which are usually solitary and usually in the periphery. They are well circumscribed with sharp borders. The pigment blocks the choroidal fluorescence, and where the pigment is absent, one can see the choroidal vasculature. Melanin, for any reason, whether it is from the above lesions and diseases or from scarring or reactive hyperplasia, will behave just as in the prior example of chirpy. Here's a patient who has both diabetes and an old chorioretinal scar. The very black melanin is blocking the dye. Now you notice at the level of the pigment epithelium, because on the angiogram you can see the retinal vessels quite easily, and therefore you know the pigment is deep and it is not migrated into the superficial retina. Choroidal nevi will block the normal fluorescence from the deeper layers of the choroid, but in later phases may show a normal pattern of fluorescence on its surface. In this example, it's a fairly early phase of the angiogram, and you can see blockage of the normal choroidal fluorescence secondary to the choroidal nevus. There's also a very prominent area in the central macula that shows the normal hypofluorescence, but it's a little bit more exaggerated in this particular case. Now we'll move on from pigment causing hypofluorescence to hemorrhage. Hemorrhages, wherever they occur, at whatever layer, will block fluorescence. If the hemorrhage is anterior, it'll block the anterior retinal vessels. If the hemorrhages are deeper in the retina, you will see the retinal vasculature, but the choroidal features will be blocked. Knowing the layer of hemorrhage is important, as it will start you down a specific differential diagnosis pathway based on the location of the hemorrhage. For instance, pre-retinal hemorrhages are generally caused by proliferative retinopathies, such as diabetes, vein occlusions, or sickle cell retinopathy. Subretinal hemorrhages, on the other hand, will be caused by subretinal or choroidal neovascularization. The two major exceptions to this rule will be macroaneurysms and trauma. We'll start here with a very anterior hemorrhage. This is a vitreous hemorrhage. This patient has diabetes and bled into the vitreous cavity. You can see the reddish appearance on the color photograph. It is covering the major retinal vessels and partially the optic nerve. You notice in the vitreous and not pre-retinal because there are no sharp edges to the hemorrhage. The hemorrhage blocks view of any normal or abnormal fluorescein in the retina. Here's a patient with diabetes and a pre-retinal hemorrhage. This hemorrhage lies between the posterior hyaloid cortex and the internal limiting membrane of the retina. The clinical photograph shows a typical boat-shaped pre-retinal hemorrhage overlying the inferior arcade. The posterior hyaloid gives a shiny reflex overlying the hemorrhage on this particular patient. The angiogram shows some abnormal hyperfluorescence from nevascularization at the nasal edge of the pre-retinal hemorrhage, but the fluorescein from the retinal vessels in the inner retina are blocked by this hemorrhage. Here is an example of a patient who has a macroaneurysm which bled. Macroaneurysms are just about the only process which can give hemorrhaging in all layers of the retina. The red arrow points to the pre-retinal blood. If you look at that area on the angiogram, you can see that the normal fluorescence of the retinal vessels is blocked. The black arrow points to subretinal blood. You can see that the choroidal fluorescence is blocked, but you can see retinal vessels in this area. The blue arrow points to intraretinal hemorrhage, and the white arrow points to the macroaneurysm itself. This is our final example of pre-retinal hemorrhaging at this time. This patient has sickle cell retinopathy. On the clinical photograph, you can see the red pre-retinal hemorrhage, and you can see some neovascularization in the periphery. On the fluorescein angiogram, the neovascularization shows quite easily as hyperfluorescence, but the pre-retinal hemorrhage does show blockage of some of the fluorescence from the neovascularization and also from the normal retinal arteries. The differential diagnosis of intraretinal hemorrhages is extremely long, and it is not appropriate to go into all the different causes here. but the most common ones, and we'll show examples of diabetes, vein occlusions, hypertension, and then macroaneurysms and leukemia. This patient has diabetes with severe retinopathy. The most prominent finding are the severe intraretinal hemorrhages, which block the normal fluorescence. But if you look closely, you can see a vascular loop and neovascularization along the supranasal arcade, so this patient also has some early proliferative diabetic retinopathy. Here's another example of intraretinal hemorrhaging, and it shows some interesting features. This patient has a hemi-central retinal vein occlusion. You can see some very superficial retinal hemorrhages just superior to the nerve, and these hemorrhages blocks the fluorescence from the major retinal arteries and veins just superior to the nerve. More peripherally, the hemorrhages are deeper in the retina, and you can see the fluorescein in the retinal vessels overline the retinal hemorrhages, but the retinal hemorrhages are blocking the choroidal fluorescence. The most common reason for subretinal hemorrhaging will be choroidal neovascular membranes associated with macular degeneration. Other causes of subretinal neovascularization can include histoplasmosis or any condition which can break Bruch's membrane, thus allowing the capillaries from the choriocapillaris to grow into the subretinal space. Macroaneurysms can also bleed under the retina, as you have seen in a prior example, and obviously trauma can cause subretinal bleeding as well. This patient has bled under the retina from a choroidal neovascular membrane. The clinical photograph shows not only the hemorrhage, but the central macular atrophy that she has with her degeneration. Also, inferior to the atrophy, you can see some yellow drusen. The fluorescence of the retinal circulation can be seen quite easily over the hemorrhage, but the hemorrhage blocks the dye and all fluorescence from the choroid. There's a window defect inferiorly, and this corresponds to the atrophy that you can see on the color photograph. And then also there are punctate areas of hyperfluorescence, and these are secondary to the staining of the retinal drusen. Here is a 78-year-old female who has had blurred vision in the right eye for about 3 months. She stated that her vision is peripheral only in that eye. The color photograph shows a classic subretinal neovascular membrane. It is gray-green in color, and it has some hemorrhaging at the leading edge. The fluorescein angiogram shows hyperfluorescence from the neovascular membrane and blockage at the leading edge secondary to the blood. This 36-year-old suffered blunt trauma to the right eye. On the color photograph, you can see subretinal blood in the central macular area, and there's also a possibility that there's some sub-RPE blood as well. This blood blocks the dye on the fluorescein angiogram. You can also see a linear area of hyperfluorescence, and this is where he had his choroidal rupture. Superficial membranes can be associated with any proliferative retinopathy, some congenital abnormalities, or some severe epiretinal membranes. These membranes are translucent and they can block fluorescence, although the blockage is not as dark and dense as the hypofluorescence caused by blood and melanin. This patient has advanced proliferative diabetic retinopathy. As mentioned earlier in the session, diabetic retinopathy is a retinal problem, and any neovascularization or fibrosis will therefore be anterior to the retina. It will not be subretinal. You can see the white fibrotic membrane extending from the nerve along the supratemporal arcade in a very dense area above the supratemporal macula. There's also other fibrosis going down inferiorly as well. The fluorescein angiogram shows hypofluorescence on the nerve secondary to neovascularization. You can see the dots of hyperfluorescence from the prior pan-retinal laser photocoagulation. But the white circle shows a bit of blockage, and this corresponds to the area of the fibrotic membrane. Here's an example of a very severe epiretinal membrane. You can see on the colored photograph the white gliotic membrane. The central architecture of the macula is quite distorted, and the vessels are very tortuous and pulled into this membrane. The distortion can be seen easily on the fluorescein angiogram as well. The central gliosis blocks the fluorescein centrally. There may also be a little bit of hypofluorescence as the xanthophyll in the central macular area is bunched centrally as well by this membrane. Abnormal fluid can occur at different levels of the retina. Just as blood, they will have a different cause and a different clinical appearance. The edema may be bright white, as in the case of cottonwool spots, or have a creamy color for deeper retinal edema, or a clear elevation of either the nerve sensory retina or the RPE, as in cases of central serous or pigment epithelial detachment. If there are inflammatory lesions, there may be a thick subretinal exudation, and that can also look creamy or yellow. Cottonwool spots are caused when capillaries in the retinal nerve fiber layer are blocked. The nerve fiber layer will become edematous and it will look white. The hypofluorescence in this situation is not as dark as that caused by blood. In fact, the hypofluorescence is most likely a combined effect of a retinal filling defect as well as blockage from the retinal edema. On this angiogram, you can see delayed filling of the infratemporal retinal vein as well. This patient has suffered an inferior branch artery occlusion. The inner retina is creamy colored from the intraretinal edema. There's one faint cottonwool spot along the inferior arcade. The white arrow on the angiogram points out the lack of filling of the more distal arteriole. You can see the relative hypofluorescence in the lower half of the macula, secondary to blockage by the edema, and this is in contrast to the normal appearance of the retinal system in the superior half of the macula. Because the blood flow is very slow, the inferior vein has not yet filled, and the blue arrow points to this non-filling of the inferior vein close to the nerve. At this point, I would like to show you a comparison of the hypofluorescence of the last patient to another patient who has hypofluorescence but from a filling defect. The patient in the upper and lower right side has proliferative diabetic retinopathy and capillary loss. You can appreciate the darker areas inferiorly where he has no capillaries. Then compare this darkness to the relative hypofluorescence of the artery occlusion on the upper left angiogram, where the capillaries are still intact, but the retinal edema gives the blockage of the deep retina and the choroid. This patient has a neurosensory detachment from central serous choroidopathy. The photoreceptors are lifted away from the pigment epithelium, and that space is filled with serum, which is why it is called central serous. The clear elevation can be seen easily on the color photograph. Where there is the elevation, you do not see the choroidal markings very well. There's a corresponding hypofluorescence of blockage by this fluid that you can see on the fluorescein angiogram. There's a beginning smokestack sign that you can also see nasally, and that is the cause of the neurosensory detachment. This patient has a retinal pigment epithelial detachment. The RPE is elevated as opposed to the last example where it was flat and only the neurosensory retina was elevated. The angiogram shows a subtle area of hypofluorescence at this stage, and the OCT below is a good cross-section of the retina so you can see the location of this fluid quite easily. In the final section, we'll talk about some of the miscellaneous processes that may give blocked choroidal fluorescence. These may include Stargardt's disease, adult onset foveal macular dystrophy, Best's disease, and sometimes deep exudation. This is a patient who has Best's disease with a vitelliform lesion centrally. You can see this as the yellow spot in the fovea in the color photograph. The fluorescein angiogram shows blockage of dye centrally by this yellowish material. Of interest, the EOG was 1.43 in the right eye and 1.74 on the left eye. This patient has severe hypertension with prominent heart exudates from her microvascular angiopathy. Some of her microangiopathy shows hyperfluorescence on the fluorescein angiogram. The exudates, some are mid-retina and some are deep, and on the fluorescein angiogram do block the choroidal fluorescence. This is a patient with a very unusual diagnosis, and that is exudative polymorphous vitelliform macular dystrophy. In the past, it used to be known as multiple Best's. There's subretinal exudation, and you can see these as the multiple yellowish elevations of the retina. The fluorescein angiogram shows blockage of the choroidal fluorescence by this exudative material.